Good afternoon. My name is Tierra Moore, and I'm here to talk CAUTIs, catheter-associated urinary tract infections. Let's talk. You get a UTI, you get a UTI, we all get a UTI if we don't fix this problem. This project is about catheter-associated urinary tract infections, and they are one of the most common hospital-acquired infections. That means when you come to the hospital, you get it from us. Basic and specific practices have been put in place in different hospitals to reduce CAUTIs. However, it's still a problem. Today we are going to talk about the prevalence and the extent of CAUTIs. We're also going to review some evidence-based practice to show you how we can prevent CAUTIs. And also we are going to discuss some strategies to reduce them as well. Here are some statistics that I got from the CDC. It said, according to them, UTIs are the most common type of healthcare-associated infections, accounting for more than 30% of the infections reported by acute care hospitals. Basically, all healthcare UTIs are caused by the insertions of catheters, and they have been associated with increased morbidity, death, hospital costs, and the length of stay within the hospital. Hospitals and nursing homes combined have had more than 1 million catheter-associated urinary tract infection cases. The Centers of Medicare and Medicaid are no longer reimbursing for catheter-associated urinary tract infection. So if we give you a UTI from a catheter, we are not getting reimbursed by Medicaid and Medicare. It says there's an estimated 565 million additional healthcare costs and approximately 13,000 deaths associated with CAUTIs each year. So basically, these are problems within the healthcare system. Although there's been practices put in place to decrease them and prevent them, like I said, it's still a serious problem to our patients. So the cause of this problem is it's either the bacteria from the patient or it's the bacteria from the hands of the person inserting the catheter. Also, the bacteria goes into the bladder via the external source from the bacteria from the outside or from inside of the catheter if there's a break or a leak within the closed system. When you put in a catheter, you have a 3 to 10% chance daily of getting a UTI. By day 30, it's a 100% chance of that person having a UTI. When we insert a catheter, we create infection, we increase morbidity, mortality, hospital costs, and length of stay. So, on adult medical surgical units, in patients with catheters placed in is routine and as needed catheter care with antimicrobacterial solutions alone enough to prevent catheter-acquired urinary tract infections. This is something that we want to know. Based on this article that was written, the purpose of this study was to see if a remindering system was helpful in removing catheters on time. So it proved that if we have a reminder system in place that lets us know that the catheters need to come out, our infection rate will decrease and our catheter days will decrease as well. So a reminder system is a good way to decrease the risk and the chance of getting CAUTIs. On this second article, this article was about removing in a timely manner. Once you have a catheter in place, you want to remove it within day 1 or 2. You don't want to leave it in there for 5 days. If it's time for it to come out, it's time for it to come out. So it had led to support that nursing computer systems and interventions will get catheters out on a timely manner. And if it's up to the nurses instead of the doctors, that we'll be able to get them out on time. This article talked about exploring the different cleaning agents that we use to maintain catheters when they are in place. The research showed that it does not matter if you clean it with antimicrobial solution or rather soap and water. It's best if you just clean it with soap and water, because you cleaning with the aseptic technique will not make any difference. So, when is a urinary catheter necessary? If your person or if your patient has acute bladder retention or obstruction after surgery, or just if they have it, if they're an elderly person, then you would place a urinary catheter. If a patient goes to surgery, you will place a urinary catheter. And sometimes when a patient comes out of surgery, they will still have a catheter, but it's best if you take it out as soon as possible. If a patient has a wound, we have elderly patients that have sacral ulcers, ulcers on their heels, ulcers on their arms in different places. If they have wounds that need to be cared for and they are incontinent, you can place a catheter so you won't be introducing bacteria to other places. If you have a patient that has prolonged immobilization, that they can't move to some nature, then you can place a catheter. But even to this situation, you don't necessarily have to put an indwelling catheter in. We have new devices called a PureWick, which is a device that you stick in between a female's legs, and as the female pees or urinates, it sucks it up into a canister. You also have a condom catheter for men as well. And you can use a urinary catheter for end-of-life situations. When is a urinary catheter inappropriate? For a substitution. If you come into the hospital, if you have a patient, oh, I don't want to move, oh, I need this. You have a lot of people coming into the hospital and asking for urinary catheters. That is not a reason for them to have one. If you need a urine sample, that is not a reason for you to have one. You can get, especially if a patient can void, that is not a reason to insert an indwelling catheter. And like I said, post-operatively, just because they had surgery and they may not be able to move like they want to, that is not another reason for them to have a urinary catheter. So, with the changes ahead, we want to use urinary catheters only when they are appropriate. We want to use aseptic technique when inserting the catheters. You want to make sure you clean your hands. And if you make a mistake and go into the wrong area, into the vaginal area with the catheter, you want to make sure you get you another one. It doesn't matter, you want to get you another one. Don't try to be like, I just stuck it here and you're going to stick it up there. No, we want to get another one. Duration, we don't want to leave it in. We want to get them out as soon as possible. And we also want to look at alternatives. What alternatives do we have to use instead of inserting an indwelling catheter? Can we do a bladder scan first just to see how much a person has in their bladder? Because they might not have as much in their bladder as you think they do. So you want to bladder scan them first. But if they need it, you can use a condom catheter, a PureWick, or you can do intermittent catheterization. When I mean intermittent catheterization, that means you straight cath them. You get what's in there, you get the urine volume out, and you let that be. And if they can't pee after the fact, you go back in with a straight catheter. You don't want to leave anything up there that sits and accumulates bacteria. On the maintenance of the catheter, if they have an indwelling catheter, you want to make sure the system stays closed. You don't, if you have any kind of leaks in the line, you want to make sure you're changing the bag if need be. You want to make sure that your urine is flowing properly. Make sure there's no kinks in the line, no knots. Also, if you have a patient, sometimes you have patients that get in wheelchairs with catheters. Make sure that the catheter bag stays below the bladder. If you sit a patient in a wheelchair, you sit the catheter bag on top of them, that's not what you need to do. You want to make sure the bag always hangs below the bladder so you won't have any kind of backflow going into the bladder. You want to empty the bag on routinely every 4 hours, every 8 hours when it's full, and you want to make sure the spigot doesn't touch the floor, any kind of unsterile surfaces, and you want to complete routine hygiene when you have patients with urinary catheters. So if we do what we're supposed to, we'll be managing change well. And we'll have daily reviews of patient with catheters. If you have a patient, you come in and your oncoming nurse, you want to say, how long has this patient had this catheter? Is it time for it to come out? Should I pull it in the morning? You know, talk with your other nurses and check the orders to see if it's supposed to come out post-op day 1, post-op day 2, or if it's an order to maintain the Foley. Sometimes you have orders to maintain the Foleys. We're gonna have standardized reminders up around, making sure that we're checking for the catheter's duration and other things like that. And also the doctors can have in place automatic stop orders that it should come up once the order is in. By day 2, it should have a remove Foley if it hadn't been removed by now. And if we have nurse-directed protocols to discontinue catheters, nurses can make the decision whether it's time for the catheter to come out. They can take it out without a doctor's order, and if need be. By getting our data and making sure that we're doing everything right, we'll have audits. And we'll calculate the compliance rate based off documentation that we have in our system. And we'll also use previous data that we've had in the past to compare and contrast to see if we're increasing or decreasing in our CAUTI rates. If we do all of this, we'll have guaranteed results. We expect a decreased number of infection rates caused by the catheter and a decreased number in catheter days, either to no use of catheters or to removal by day 1 or 2. There will be a reduction in patient discomfort, length of stay, and deaths caused by CAUTIs. Also, it'll be resulting in less cost for the hospital and an increased reimbursement by Medicaid and Medicare for services that we provided for these patients. Successful change can occur based on research evidence that it is proven that you can decrease catheter-associated urinary tract infections. Any questions? If you don't have any questions,
I have a question. When do you plan to implement this process of change?
This process and change is being implemented at this time. I think it'll take about 3 months to fully get it going, so everybody's on top of their situation as far as checking and making sure they take the Foleys out and make sure they check if it's time to come out. But it's being implemented at this time.
Okay.
That's it. Thank you, guys.